Bismillah ar-Rahman ar-Rahim. Thank you, Mr. President, Mr. Chairman, Co-Chairman, Dr. Oslam, Professor Tamil Ragal. Thank you very much for holding. Actually, our nightmare is the primary graft failure. We had the pleasure to be one of the students of Mahmoud Ismail, who invented the deep anterior lamellar, and it was my pleasure to learn it from him. It's injecting.
Excuse me, can you have the discussion outside if possible, please?
It involves injecting air to create an air chamber, and this is how it looks from inside. This is an air chamber for done, but the case was not suitable for deep anterior lamellar. So with any cornea, you can get this effect very, very early in the post-operative. Sometimes you have a double chamber and you can end that surgery, and then you might be lucky and it's resolved by itself, leaving a small, tiny break in the Descemet's endothelium component. And how to relieve it? We all have done such maneuver. We empty the anterior chamber. We use to constrict the pupil. We dehydrate the anterior chamber to leave the tension soft as possible, inject air, leave the patient laying down, and then you get everything done. Now, this is a young male dentist. I did him bulk, and then after 2 weeks, he was getting the best vision that he expected. I was his hero, and he used to come to me and tell, "You are my hero." And after 2 to 3 weeks, suddenly he had a drop of vision and foggy vision, and the vision started to be very foggy, and the patient is furious. And then it looked like this. This is his cornea. And I was so astonished. What happened to this patient? Thin detached Descemet membrane, and there was some stretch marks. So rapidly, I started to make documentation with the anterior segment OCT, and this is how it looks. And I had to fetch help for a professional center doing us the investigation in the center of Cairo, and they confirmed the evidence of Descemet detachment centrally. So why it's very late? What is the significance of stretch marks? But the cornea is not so cloudy as usual, and this doesn't look like double anterior chamber. And I'm sure that they didn't break the Descemet membrane during the surgery. So what happened? I don't know. So I followed more the patient, and the patient each time comes more furious than before. And I decided to take him to surgery because I was not convinced that this is a Descemet detachment. It was a retrocorneal membrane. A very curious case of retrocorneal membrane that happens only 2 weeks after bulk surgery with no inflammatory incidents. And I had to go inside aggressively with an inverted cystitome and take it out. And this is how it looked. A full membrane, full inflammatory membrane. So, against all the odds in the world, I proceeded for an aggressive surgery, and this is the outcome. Fabulous. Dramatic improvement, that the patient comes back with his vision 0.5 without correction. And here it looks in the street lamp video. Some tiny part of the detached, with the membrane down that I couldn't really scrap. I was afraid to scrap it all. But the patient recovered his vision, and it was very astonishing. We all know what's meaning of retrocorneal membrane. Actually, it was very famous, very common with the prosthesis, the keratoprosthesis. We have seen it all. And it was one of the reasons that really frustrates me with the keratoprosthesis, and you cannot do anything about it. It's a complete failure if you try to scrap a retroprosthetic membrane. Actually, this is a funny snapshot from a video of a patient Probably he did the prosthesis with me because he's blind and he drives the motor all over Cairo. Thank you very much.
We had a few minutes for discussion. By the way, interesting. Did you do specular microscopy for him?
After?
No, when you had that membrane, at least you
But-
know this is the membrane, the deuterium is still there and this is something behind.
Actually, I was not convinced that this is the descent detached.
I know, but
And,
if you did cell count, but I mean, you could see that this is the
I sent-
cornea.
yeah, this is,
and that's something not
You
normal.
might destroy the cornea if you go aggressively. I mean, if you are not sure that this is a retroprothetic membrane and it's a Descemet's detachment, so definitely this cornea will go cloudy instantaneously. The stretch marks. There is no Descemet's membrane detachment with stretch marks. Impossible.
Yeah, I agree with you. It's so straight that when we have double anterior chamber, it's wavy, and we see that the detached DSMS is longer than the
not stretched like.
Yeah, not stretched like that. So it was a very good management.
Actually,
congratulations.
I did him the OCT anterior segment in my center. We have a small center in the periphery of Cairo, and the guy who did me the imaging, he was convinced that this is Descemet detachment.
Maybe he doesn't see that much double anterior chamber.
I told him I cannot recall that there was a defect because Descemet detachment, even if it's tiny, Descemet breaks during the surgery, even if it's tiny, you can notice it because some air will come, some fluid with air will come. You will notice it somehow. But I don't recall that this happened to me. Also, when I sent it to a professional group of doctors, they have a specialized center in ophthalmology, eyes imaging, and they are very clever actually. And this was their report, the other one that so in our centers they insisted, and in the professional guys it was then in the city center, and they also. They sent this report that you have seen, but clinically, as you said, Professor, it's not it's not matching.
Thank you, Professor Mahmoud, for this interesting case. Suppose before having this membrane, we have fibrinous reaction or something.
Nothing.
Yeah.
Actually, this is a quite I have seen in the first. Actually, I didn't image him when he came in the early postoperative because he was fine. I imaged him when he came furious. And let me tell you something, and this is very ugly. When the patient, nowadays the patients are spoiled actually. When the patient gets very good vision and he suddenly drops his vision, his state of mind changes, his attitude changes. So I'm asking him some silly questions and the patients come even more furious. I told him, did you have any trauma? So he starts to be more furious when you ask him some silly questions because you don't know what happened. You are surprised with the such reaction.
Did you think to do YAG laser for this membrane before doing the surgical?
I thought about it, but look, Professor Temet, I set my mind that this is not a Descemet detection. Okay, so this is because the cornea is not cloudy. The stretch marks, as I mentioned, that as you have seen, and this Professor Osman also have agreed with me that such kind of imaging is not really undulated. The undulated image of a wavy image of the Descemets, ruptured Descemets. So I thought that if you just perforate with YAG laser, with the hazard of YAG laser on the good endothelium, it's not enough, and you don't know if it will return back or not, or it keeps reformation.
Thank you, Dr. Mahmoud. Thank you very much.
Thank you, sir.
And next speaker, Dr. Manisha Ashari. She will talk about retroendothelium scraping technique in action.